Sushmita Kaushik again for her talk on digital workflow for diagnosis and management of glaucoma. Dr. Sushmita, please.
Sorry, I didn't know they weren't the speakers. Thank you very much again. This was a digital workflow. I thought this is something which we do every day. So it's not going to be very theoretical as what is possible, but I'll just touch upon how we work in our crazy clinic as we do. No financial disclosures, alas, though I'd be talking so much of Forum and Zeiss. So what is a digital workflow? What is possible? And like I said, snapshots of use in an everyday clinic. So in glaucoma or retina or cornea nowadays, you know that we have dozens of digital imaging modalities. And we use them to diagnose, we use them to monitor, and we also use them to document treatment effects. So the DICOM revolution has really helped. The DICOM is a digital imaging and communication in medicine. That's what it means. So this is the usual flow. We enter data, the optoms do all the measurements that they want, then the clinic is, of course, they're registered, they're archived, and then the DICOM sends out these images to the clinicians who are sitting in their respective areas. And for instance, for glaucoma, you'll have an OCT, you'll have a visual field, you'll have a disc picture. And then by the time the patient comes to you, hopefully on your screen, you have all of these, and it helps you make an informed decision of what needs to be done when the patient is in front of you. So that's in a nutshell what usually the DICOM is used for in the context of glaucoma. So an example is the Forum, which is what we have, which is by Zeiss. You can have interactive visual field data on one machine. You can have many, many fields which you can alter. If you think that some fields are not good, you can take them off the grid. If you think that an intervention has been done, you can reset baseline, so you can do a lot of things. You can do structure and function GPA by the Cirrus OCT and the visual field, the Humphreys analyzer if you can. And you have structure and function reports, which includes 24-2 as well as 30-2. A caveat of this is if you have a very, very busy clinic and hundreds and hundreds of patients, your machines can't incorporate them. So what is usually done is they are sent out into the server. If you don't have data in your machine, you cannot do a structural GPA, which is why that is a limitation of space and the limitation of having humongous data on an OCT machine currently. So most very, very busy clinics will not be able to have a structured GPA, so keep that in mind. So in the clinic, for instance, now you have this 84-year-old normal tension glaucoma, pressures of 14, advanced glaucomatous optic neuropathy, also wet AMD, and bilateral TRABs done. So when this patient comes into me, what are the two questions? Is this pressure okay for him, and how can I help? So we open the Forum. So then what happens is you have all your patients here, then you put in the number, then all his investigations that have been done over so many years opens up, and then you open up today's. And today's you have visual field, you have GPA, you have the OCT, you have the single field analysis, so you have all these pictures which are there at you. Now you want to concentrate on what's he like when he came. So I scroll down and I realize, oh, this is what he was when he came in. So when he came in, he was as advanced as this, which is like 15 years ago. So you tell yourself, 15 years ago, this is what he was, and then the TRABs have been done, and now, so far so good, this is how he is. So pretty much stable, and he's doing all right. Now that the surgery's been done, how do we interpret the GPA? Because it will always, always show up as progression from the baseline. Whatever you do, this patient is always going to be worse than what he was because the GPA, remember, compares baseline to today. So how do you know after you've done surgery? Is there something you can do? So what we can do is we can mark it. So we mark the baseline as the point at which we've done surgery, and Zeiss allows you to put a little knife there to tell you that you've done surgery, and the rest of the GPA will then be computed from the second baseline. So that's the interesting and the useful thing that we can do. Well, surgery in the right eye, I don't think it's too visible. the visual fields had worsened. Now you're wondering what has happened. Why have the visual field in the right eye worsened? So you can see that the rate of progression was -2, and when you did surgery and after that, the rate of progression is -4. And then you're looking at yourself and you realize the culprit is the macular edema. So that is also there on your digital workflow, and then all you do is give a call to your retina colleague and say, hey, you know, this guy needs an anti-VEGF or something. And then he comes the next time, the macular edema is better, and then you can ask for another visual field and do it. So you can all do this while sitting in one chair and all your DICOM images coming to you. Another typical clinic flow would be a 45-year-old PACG, best corrected vision 6/9, IOP 32 and 30, and laser iodotomy is patent. Now the question is, how bad is the glaucoma? What are the discs? What are the fields? And is the lens a problem? She's only 35 years or 45 years old, and she has patent iridectomies and yet 30 pressures. So order tests, do the same thing, open up the forum, look at, so this entire thing will open up to you, and you can see that the discs are okay, the fields are not too bad. So the next question is, why is the pressure so high? Is it the lens? And then you look at both of them and you realize that the lens vault is more than 1,000 microns. So you think this patient probably needs an early cataract surgery. And once a cataract surgery is done, you realize that the angles have opened up and the pressures come down to normal. So you can open up the pre and you can see the post and you realize, okay, so this was the problem. So it helps decision making. Currently all is well. Fields are still fine, pressures are under control, discs are okay, and hopefully she'll remain okay for a couple of years too. So this really improves efficiency. I think it saves time. Decision making is easier because we have everything on one computer rather than looking through and sifting through lots of paper, and follow-ups have better visualization. Thank you.
Thank you, Dr. Sushmita. As usual, a very wonderful talk.